1, 2, 1, 2, 3. 1, 2, 1, 2, 3. One, two, 1, 2, 3. 1, 2, 1, 2, 3.
check. Veteran Service Organization. The subcommittee will come to order. Before we begin, I would like to ask unanimous consent for our colleague and fellow committee member, Representative Kaufman from Colorado, to sit on the dais and participate in today's proceedings. Without objection, so ordered. Good afternoon. Thank you all for joining us. Today we'll be discussing a number of bills that have been referred to the Subcommittee on Health, as well as two draft proposals that are sponsored by Chairman Rowe and Ranking Member Walls, respectively. These bills, which are sponsored by committee members and colleagues from both sides of the aisle, would address some of the most important health care issues facing our nation's veterans and the Department of Veterans Affairs. H.R. 1506, sponsored by Congressman O'Rourke, would address VA's longstanding recruitment and retention challenges by increasing the caps for VA's education debt reduction program. H.R. 2322, sponsored by Congressman Walberg, would improve care for injured and amputee veterans and clarify what those in need of prosthetic and orthotic care are entitled to from VA, including access to timely and quality care either in VA or in the community that best meets their needs and goals. H.R. 3832, sponsored by Dr. Dunn, would help prevent opioid abuse among veterans by allowing for the greater sharing of information between VA and state-based prescription drug monitoring programs. H.R. 4334, sponsored by Congressman Correa, and H.R. 4635, sponsored by Congressman Kaufman, would improve care for women veterans by collecting information regarding access to gender-specific care in the community and environment of care standards in VA medical facilities and requiring a sufficient number of peer-to-peer counselors for women veterans, respectively. The draft bill, the VA Medicinal Cannabis Research Act of 2018, which is sponsored by Ranking Member Walls, with Chairman Rowe and Congressman Correa as original co-sponsors, would authorize VA to conduct and support research on the efficacy and safety of medical marijuana for veterans with chronic pain, post-traumatic stress disorder, and other conditions. Finally, the draft bill to make certain improvements in the Family Caregiver Support Program, which is sponsored by Chairman Rowe, would require the implementation of an information technology system to support VA's Family Caregiver Support Program and then reform and expand that program. I look forward to learning more about each of these bills and draft proposals today. I'm grateful to each of the bill sponsors for their leadership on these issues and for being here to testify on our first panel. I'm also grateful to our Veteran Service Organization partners for being here to provide their views on these bills on our second panel. I now yield to Ranking Member Brownlee for any opening statements she may have.
Thank you, Mr. Chairman, and Ranking Member Walls for being here, and thank you to all of today's witnesses for participating in our legislative hearing. I'm excited to discuss the legislation on today's agenda. Each piece of legislation is in response to a serious issue or concern affecting our veterans' health care. I look forward to hearing from our witnesses, addressing any concerns ahead of a future markup and moving these important reforms forward. As a co-sponsor of several of the bills before the subcommittee today, I'm proud of the work being done within this committee and throughout this Congress to preserve and enhance the VA health care, and that's so that many veterans utilize, value, and recommend. During my time on this committee, I have made it a special priority to ensure women veterans have access to high-quality, gender-specific care in a safe and welcoming environment. I believe that two of the bills on today's agenda will advance this goal. The Improving Oversight of Women's Veterans Care Act requires the VA to practice oversight on the community care providers that the VA contracts with to provide gender-specific health care to women veterans. We need to do a better job tracking the quality of care provided to women veterans and conduct effective oversight to ensure they are well served no matter where they get their care. I'm also excited to lend my support for Congressman Kaufman's legislation to require the VA to ensure that veterans' peer counseling programs includes enough peer counselors for women veterans. It is clear that peer-to-peer counseling is an effective way to reach veterans that may not be willing to submit to a formal mental health care treatment plan. Peer-to-peer counseling is meant to be sensitive sensitive to the specific culture of the military and how that culture affects a veteran's experience. It is integral that veterans seeking peer-to-peer counseling are afforded an opportunity to speak with a peer that they can relate to. And for many women veterans, their most relatable peer will be their fellow women. I appreciate Congressman Kaufman's leadership on this issue and look forward to further discussions on the merits of his legislation. Finally, I'm eager to hear from the ranking member of the VA Medicinal Cannabis Research Act of 2018. I'll leave it to the ranking member to discuss its merits, but I will say I'm proud to co-sponsor the legislation because I believe the VA must continue to look at complementary and alternative treatments such as cannabis that can help veterans cope with the invisible wounds of war. Thank you also to Congressman O'Rourke and all of our colleagues for your legislation and your work supporting veterans. I look forward to your input and recommendations of our VSO partners. And Mr. Chairman, thank you, and I yield back.
Thank you, Ms. Brandley. We are honored today to be joined by Ranking Member Walls, who will be speaking about his respective draft proposal. And I want to thank you for being here today. And we will recognize you for 5 minutes for any comments you may have before we begin.
Well, thank you, Chairman and Ranking Member. Thank you both for your longstanding bipartisanship and your ability to bring good, solid pieces of legislation forward that are able to be passed into law. I'm grateful to be here with you. As a point of personal privilege, I wanted to point out we're joined today by a nonprofit from Minnesota, Wiggle Your Toes. Folks we're just talking to that mission statement is pretty clear that they're out here to make sure that folks who've lost a limb have the capacity to be able to get back the life that they want, working with our veterans as well as some of our heroes in the Boston Marathon bombing, appropriate this week. So thank you for being here. And I will note that at least one of the members here today is a fellow alumni of Minnesota State University Mankato, which the chairman knows as the Harvard of the Midwest in its more common name. So just so you know. But thank you for that. I appreciate the opportunity to put this forward, and I want to thank the chairman of the full committee, Dr. Rowe, for working with us on this, and my friend and colleague from California, Mr. Correa, has been a champion of this. We all know that the issues that come with pain, whether they be physical or the mental injuries that come with serving this nation are great. We understand that there are incredibly powerful drugs that are able to help at times, but we also know the dangers of the abuses of opioids and other therapies that we want to try and move folks to. The VA has always been, since the early 1920s, this nation's premier research institution, and they have a cohort of folks that we owe it to get the best possible treatments to. And one of the things that we're seeing across the country is veterans understanding that the potential for medicinal cannabis is great. And what we need to know and what this act does is very simple. It simply clarifies that the VA has the capacity and the authority to do research into medicinal cannabis, and then it asks them to update Congress on where they're at. It doesn't mandate that they do it. It doesn't tell them to do it. It asks us to try and find the data to make sure it's there. And what this does is clarify, because there have been some confusions, and the VA believes that because of being labeled a Schedule I drug, that they do not have the capacity to do this. They have the largest cohort. We have veterans suffering. We have the opportunity to do the research and then find out once and for all if we can put this in. We have a patchwork system right now. If you're a veteran in one state, you have access to medicinal cannabis. In another, you do not. We don't have the hard research to show that the best way that we can do this. I want to give a special thanks to some of the partners in this, the American Legion, who has come out and asked us to find out if this works, find out the research, the VFW, and others. This is just one of the many things, and I'm proud of all of you we worked on here. It wasn't that many years ago when we were talking about acupuncture or yoga being alternative therapies that couldn't be embraced. Now we have those things in the VA. This is the next step of ensuring that the VA has the best possible research, the best possible data, and if it is going to provide relief for our veterans, we should be looking into what is the next step in medicinal cannabis. So, Mr. Chairman, I thank you for that. I thank you for the opportunity for introducing this. And again, I want to give a big thank you to Chairman Rowe. We have a lot of medical doctors on this committee, and I truly look towards your judgment and your ability to understand what we need to do to make sure before we start prescribing these. So thank you.
Thank you very much. I now want to introduce our first panel. It's a pleasure to be joined today by several of our bill sponsors, and I appreciate y'all taking the time out of your afternoon to be here. With us here today is Congressman Beto O'Rourke from Texas, Congressman Tim Walberg from Michigan, Congressman Neil Dunn from Florida, Congressman Luis Correa from California, and Congressman Mike Kaufman from Colorado. Mr. O'Rourke, if you are ready, you are now recognized for 5 minutes.
Thank you, Mr. Chairman. I wanted to speak a little bit about H.R. 1506, the VA Healthcare Provider Education Debt Relief Act of 2017, which I think will help us to address the crisis and provider shortage that we have in the VA right now. I think by the last VA Secretary's estimate, we had at least 30,000 authorized, funded, but unhired clinical positions in the VA. Every day that goes by without those positions being hired is another day that we fail to see veterans honor the commitment they've made with the care that they need, that they deserve, and that they've earned. This bill would increase the debt reimbursement available to providers for their medical school education from $120,000 to $150,000. It would also provide the means in certain critical shortage areas to waive the cap altogether by working between the VA and the Department of Health and Human Services. This bill has support from a number of veteran service organizations. We've been working with the VA to improve the bill, and I'm grateful to have a chance to get feedback from members of the committee and veteran service organizations today about how we can get this done. And with that, I yield back. Thanks.
Well, thank you. Mr. Walberg, you're now recognized for 5 minutes.
Thank you, Chairman Winstrup and Ranking Member Brownlee. Thank you as well for giving me the opportunity to be back in this very special room, dealing with a very special constituency, and that being our veterans. And thank you for allowing me to be here today to testify on H.R. 2322, the Injured and Amputee Veterans Bill of Rights. I would like to start off by thanking the subcommittee members and staff for their time and willingness to work with me on this very important issue. I think we can all agree that our veterans have earned the highest quality possible health care. I understand there are problems at the Veterans Affairs and that this committee is diligently working to address these concerns to ensure our veterans receive the benefits and care they deserve. I also know there are great doctors, nurses, and staff that work hard to make sure our veterans receive timely care. With that being said, I believe a veteran's health care decisions are personal choices. We know all too well that the VA can be an intimidating and hard-to-navigate bureaucracy. There are layers of paperwork and red tape that can make these health care decisions daunting. H.R. 2322 moves to empower veterans when it comes to making their own health care choices, and it does so by ensuring that injured and amputee veterans know their health care rights. Years on the battlefield has taken a toll on our warfighters. Our veterans are younger than before, and transitioning from active duty can be difficult. We need to ensure that amputee veterans have the best access to care and the ability to more easily transition into civilian life. The Injured and Amputee Veterans Bill of Rights is a bipartisan approach to empowering injured and amputee veterans in making their health care choices. This bill simply requires the VA to prominently display a list of rights in a VA orthotic or prosthetic O&P clinics as well as their website. These rights include, and aren't limited to, the right to access the highest quality and most appropriate O&P care, the right to select the practitioner of their choice, the right to consistent and portable health care, including obtaining comparable services at any VA medical facility, the right to timely and efficient O&P care, the right to both a primary prosthesis, an orthosis, and functional spare. Additionally, the VA should be required to educate their staff so VA employees can help veterans navigate this process. To make sure veterans are receiving the care they deserve and need, our bill also requires the VA to follow up and resolve any complaints by veterans who believe the VA is not meeting their O&P needs. Mr. Chairman, at the end of the day, veterans should receive the best available and timely care they can get. I know this is something you and I and your staff have worked hard on, and I applaud your unwavering commitment to our veterans. I'm willing to work with you and your committee in any way to better this legislation so that we can empower injured and amputee veterans when they're making their health care choices. Thank you for your time today and for the work this committee is doing to keep our promises to our nation's heroes. Thank you.
Thank you, Mr. Wahlberg. We are honored to have Chairman Rowe here with us today. Dr. Rowe, if you would like to take 5 minutes to discuss your proposals for the Family Caregiver Support Program.
Thank you, Dr. Winstrup. It's a pleasure to be here with the subcommittee today, and there are a number of worthy pieces of legislation that we're going to discuss this afternoon. And I'm particularly interested in Dr. Dunn's bill, the Veterans Opioid Abuse Prevention Act, which would give improvement, would improve the Department of Veterans Affairs communication with a state-based prescription drug monitoring program to help identify and address opioid addiction among veteran patients. I'm also interested in Representative Wahlberg's just presented an Injured and Amputee Veterans Bill of Rights. And that bill was discussed at the committee's field hearing in Fayetteville, North Carolina a couple of weeks ago, and would clarify that those veterans who are in need of prosthetic or orthotic services through VA are entitled to the very best care at the provider of their choice in light of the unique and highly individualized needs. And I'm grateful that my draft bill to make certain improvements to the Department of Veterans Affairs Family Caregiver Support Program is included on the agenda for today's hearing. My draft bill would require VA to implement an IT system to support the Family Caregiver Program, to use the data that the system collects to conduct an assessment of the program, and to use that assessment to identify and implement needed modifications, and to certify to Congress that the IT system and modified program are both working. From there, it would expand eligibility for the program to pre-9/11 veterans, amend eligibility for the program to veterans in need of personal care services due to an inability to perform 3 or more activities of daily living, ADLs, rather than the 1 or more ADL grant. VA the flexibility to change how the monthly stipends are calculated by removing certain requirements from the current law and requiring VA to promulgate regulations regarding stipend determinations. Require a primary caregiver to reside or agree to reside in, quotes, close proximity, end quotes, with the veteran he or she is caring for, and define close proximity as one that allows regular in-home management care, supervision, or treatment. Require VA to develop and publish in the Federal Register a plan to transition those currently approved for the program to the amended program. This draft has been in development since the full committee hearing on the program in early February, and has been the subject of multiple roundtable discussions with VA and veteran service organizations since that time. While this bill remains a work in progress, I appreciate the thoughtful feedback provided in those conversations and look forward to continuing to work with all interested stakeholders on moving this forward. I know that there's been much public discussion recently about a compromise agreement between Senator Isaacson, Senator Tester, and me that would expand eligibility to the Family Caregiver Program to pre-9/11 veterans without making any changes to the eligibility criteria or stipend calculation. The inclusion of that provision was one of the chief concessions that I made to achieve a compromise agreement. I'm committed to that compromise agreement and hope to see movement on it in the coming weeks. That said, negotiations are ongoing, and I remain convinced that should negotiations prove unfruitful, we must have an honest conversation about the findings, the right balance between clinical appropriateness and the cost within this program, and make needed changes to ensure it is working as intended before increasing its participants in such a dramatic fashion. I also want to mention the draft bill offered by Ranking Member Walz and myself to authorize VA to conduct research on the efficacy and safety of medical cannabis. As a medical doctor, I've written countless prescriptions, but never once in my life have I prescribed a drug which has not been proven effective by the FDA. Allowing VA to research medical marijuana will finally allow us to separate fact from fiction and provide a scientific footing on which sound policy may be built. As you noted in your testimony, Mr. Shealy, 92% of respondents in veteran households support researching the effort of medical cannabis for mental and physical conditions. That's a statistic that should not be ignored. I thank the American Legion for leading this effort, so we might at last find out if medical marijuana is a viable treatment option for our nation's veterans. And I look forward to hearing everyone's comments on that legislation today. With that, I thank you again for allowing me to be here today, Dr. Winstrup, and I yield back to balance of my time.
Thank you, Dr. Rowe. Dr. Dunn, you're now recognized for 5 minutes to discuss H.R. 3832.
Thank you very much, Chairman Winstrup, and thank you, Chairman Rowe, for your kind words. And I appreciate the opportunity today to speak on behalf of H.R. 3832, the Veterans Opioid Abuse Prevention Act. According to the Centers for Disease Control, 249 million prescriptions were written by healthcare providers in 2013. The Department of Veterans Affairs healthcare system is the largest healthcare provider. Because of this, it's in a unique position to help curb the opioid epidemic by using every tool available when a veteran is prescribed an opioid. The Veterans Opioid Abuse Prevention Act gives the VA healthcare providers access to these valuable tools. H.R. 3832 comes directly from recommendations from the nation's top policymakers. The White House Commission on Combating Drug Addiction and the Opioid Crisis recommended last July that the VA lead efforts to have all state and federal prescription drug monitoring programs, known as PDMPs, share information. The interim report cited multiple published best practices for PDMPs and has identified interstate data sharing as among the top priorities to ensure that healthcare professionals have a better understanding for prescribing practices for their patients. H.R. 3832 directs the VA to have healthcare providers participate in the sharing of prescribing data across a network of interstate prescription drug monitoring programs. PDMPs are state-based networks which providers can access when writing or filling prescriptions, and PDMP data includes the type of the medication, the fill dates, and the dosage amounts. PDMPs improve a clinician's ability to follow good prescribing practices for at-risk patients who may have a pattern of prescription opioid abuse. In 2011, the National Board of Pharmacy created a national platform of prescription monitoring programs, PMPs, called PMP Interconnect, which allows the various states to share their PDMP data across state lines securely. Today, 44 states and Washington, D.C. participate in the PMP Interconnect, and more states are adding all the time. My own state, Florida. Now, I have veterans in my district who are desperate for opioids because well-meaning but under-informed physicians have repeatedly overprescribed opioids for them. I can guarantee everyone sitting on this dais today has veterans back home suffering from the same reason. And let me be clear, this is not something that anyone up here on this dais or in this room should accept as good treatment for veterans. The tragedy in these situations is that so many of them are preventable just by giving doctors the right tools and right information on how to prescribe these safely to which patients. And we want to make this a high priority. H.R. 3832 implements the Commission's recommendation by granting providers the ability to use an interstate PDMP platform for the betterment of our veterans who are at risk of opioid abuse. Every doctor has a duty to help the sick and according to one's ability and judgment. So as a committee, we have a duty to ensure the veterans have access to doctors who are enabled to make the best clinically informed decisions for the veterans. I encourage my colleagues to support H.R. 3832, and I yield my time back, Mr. Chairman.
Thank you, Dr. Dunn. Mr. Correa, you're now recognized for 5 minutes.
Thank you, Mr. Chairman Winstrup, Ranking Member Brownlee, and members of the subcommittee for the opportunity to speak on my bipartisan bill, H.R. 4334, the Improving Oversight of Women Veterans Care Act. And I want to thank my friend and colleague, Ranking Member Brownlee, for her support of this legislation. Women represent the fastest growing population of veterans in our society. In 2015, women represented 9.4% of the total veteran population. By 2045, this number is expected to go above 16%. Yet, according to the GAO, the Veterans Health Administration does not have performance measures to determine women's veterans' accessibility to gender-specific care. My bill will enhance the monitoring needed for effective oversight of women's veterans' health by requiring the VA to submit an annual report on veteran access to gender-specific care under community care contracts and quarterly reports on environment of care standards for women veterans. This will ensure that we understand women veterans' ability to access gender-specific health services. I understand my bill may require technical edits, and I'm open to working with the committee and others to address those needed changes. Again, I thank you for the chance to speak before the subcommittee. I yield.
Well, thank you. And Mr. Kaufman, you're now recognized for 5 minutes.
Thank you. Chairman Winstrup and Ranking Member Brownlee, thank you for allowing me to present H.R. 4635, the Peer-to-Peer Counseling Act that I introduced with Congressman Esty to improve VA counseling afforded to female veterans. I would also like to thank the members of the subcommittee who co-sponsored H.R. 4635, Ranking Member Congresswoman Brownlee, Representative Bilrakis, Representative Custer, Representative Radewagen, Representative O'Rourke, Representative Rutherford, and Representative Gonzalez Colon. Currently, female veterans make up nearly 10% of our nation's veteran population, and this population is expected to grow to 15% by 2030. Over the past 10 years, the VA has seen a 45% increase in the number of female veterans using VA benefits, demonstrating that female veterans are relying more and more on VA services. And the female veteran population, as the female veteran population increases, it is critical for VA to meet future demand. One area of need among female veterans that warrants our particular attention is peer-to-peer counseling. Unfortunately, many female veterans have experienced sexual trauma and PTSD while serving in the military and are also suffering from other mental conditions that put them at risk for homelessness. Peer counseling can help female veterans who are facing these critical issues. The VA's 2016 suicide data report found that the risk of suicide for female veterans was 2.4 times higher than non-female adult veterans, adult females, and the rates of suicide increases more among women than men. The data is disturbing. We owe it to our female veterans to ensure sufficient resources are available to assist with gender-specific needs, and that is why I introduced H.R. 4635, the Peer-to-Peer Counseling Act. H.R. 3635 enhances the VA's existing peer-to-peer program, which has been successful in providing peer counseling to all veterans by ensuring the current program has a sufficient quantity of female peer counselors for female veterans who are separating or newly separated from military service. Ideal counselors will have expertise in gender-specific issues, VA services, and benefits focused on women, as well as employment mentoring. The Act also would emphasize counseling services for female veterans who have suffered sexual trauma while serving in the military, have PTSD, or any other mental health condition, for our female veterans who are at risk of homelessness. To ensure these counseling services are not only available but also known throughout the veteran community, H.R. 4635 directs the VA Secretary to conduct outreach to inform female veterans about the peer-to-peer program and the services available to women. H.R. 4635 authorizes the VA Secretary to facilitate engagement and coordination with community organizations, state and local governments, institutions of higher learning, and local business organizations. With the help from our communities, we can leverage resources and expertise that exists within these communities. Peer-to-peer counseling. The Peer-to-Peer Counseling Act ensures VA's peer-to-peer program is better postured to address the gender-specific needs of women, veterans, and updates this vitally important program to better represent the growing veteran population it serves. Mr. Chairman, I encourage my colleagues to support this important legislation, and I yield back the remainder of my time.
Well, thank you, Mr. Kaufman. I thank everyone from the first panel for being here today, and you are now excused. I will now welcome our second panel to the witness table. Joining us on our second panel is Louis J. Chelly, Director of the National Veterans Affairs and Rehabilitation Division of the American Legion, Adrian Adezato, the Deputy National Legislative Director for the Disabled American Veterans, Sarah S. Dean, Associate Legislative Director for the Paralyzed Veterans of America, and Kata Kelcher, Associate Director for the National Legislative Service of the Veterans of Foreign Wars of the United States. While VA is unable to be here, I do look forward to receiving the Department's views for the record and appreciate our veteran service organizations for their time and attendance this afternoon. Mr. Chelly, we'll begin with you. If you are ready, you're recognized for 5 minutes.
Tree bark, mold spores, poppy, coca, rhododendrons. There are more than 100 distinct chemical substances that are derived from organic plants being used in pharmacology today. From these organic substances, we enjoy the benefit of aspirin, a tranquilizer called romotoxin, codeine, and morphine. And in 1928, a Petri dish contaminated with floating mold spores changed the course of human history by introducing the first antibiotic, penicillin. Chairman Winstrup, Ranking Member Brownlee, distinguished members of the Subcommittee on Health, on behalf of National Commander Denise Rohan and the American Legion, I'm honored to be able to testify on the following and pending draft legislation. According to the National Institute of Health, cannabis is a complex plant with over 400 chemical entities, of which more than 60 of them are cannabinoid compounds. Today, 30 states have medical cannabis laws that allow patients to use cannabis for illnesses ranging from inflammation and pain to epilepsy and cancer, and all 50 states have legalized one of the chemical derivatives, cannabidiol, or CBD, as it's more commonly known today. And yet there isn't a single physician who's been formally trained by an accredited U.S.-based medical school on what this plant can or can't do. There is no education that discusses medicinal use, drug interaction, placebo effect, dosage rates, strains, or anything else regarding this plant, because the United States Drug Enforcement Agency continues to insist that cannabis has, and I quote, no currently accepted medical use and a high propensity for abuse, as opposed to Schedule IV drugs like Xanax, Darvon, Valium, Ativan, Ambien, and Tramadol, which according to the DEA have a low propensity for abuse and low risk of dependence. The National Academy of Medicine recently reviewed 10,000 scientific abstracts on the therapeutic value of cannabis and reached nearly 100 conclusions in a 2017 report. And yet the United States continues to lag behind other developed nations by restricting scientific research into this drug. The draft legislation will call on VA to conduct the research necessary to determine if the cannabis plant, marijuana, has medical value or not. Our veterans are asking for this research, and our nation has an obligation to provide it. Next, I'll address H.R. 1506, the Healthcare Debt Reduction Act. The Department of Veteran Affairs went from 33,000 vacancies in 2016 to 43,000 vacancies today, a 30% increase. The department has been the subject of intense scrutiny over the past several years, and rightfully so. But along with that scrutiny comes responsibility, the responsibility to be fair and balanced. The VA operates the largest healthcare network in the country, some say in all the world. And just like any large organization, VA has a board of directors, you. We often compare VA to private industry. We hold them up against private metrics, quality standards, efficiencies, wait times, and cost-benefit ratios, but we fall short when it comes time to argue that the employees' pay needs to be competitive to their non-government peers. H.R. 1506 can help fix that by making VA a more attractive employment option for our healthcare community by offering to pay some of their student debt. Will this solve the problem? Not entirely, but what it will do is prove that we're willing to invest in high-quality professionals that care for our wounded and ill veterans. The Veterans Opioid Abuse Prevention Act will bring VA online with state-based prescription monitoring programs. This is in the best interest of patients and helps doctors provide holistic quality medicine at the federal level. Patients commonly have multiple doctors, and it's especially true for veterans who, because of their combat-related injuries, commonly suffer more comorbidities than their civilian counterparts. In the absence of a single lifetime medical record that can be accessed and shared among all patients, medical professionals participation in a unified database that helps guard against drug interaction and duplication of prescriptions is an important step in ensuring veterans receive proper and accurate care. Next, peer-to-peer counseling has always been a preferred counseling medium, long supported by the American Legion. VA's hundreds of vet centers were built on this very premise, and the American Legion continues to support this reliable individual peer-to-peer counseling where veterans who have had similar experiences can share their stories and tactics for recovery. That said, we support H.R. 4635. At this time, we're unable to support H.R. 2322, the Injured Amputee Veterans Bill of Rights Act, because it appears to be missing some language, which appears to be a very simple fix. The American Legion is committed to ensuring that all veterans, especially those with catastrophic injuries, receive expert care. We just have to be careful that we don't create a mechanism whereby VA has no control over how that care is delivered or how the government will pay for it. We wouldn't have an issue if the bill contained the passage that's reflected in the VA handbook stating, or the veteran's preferred prosthesis who's agreed to accept the preferred provider rate, which unfortunately this bill is missing. Thank you, and I look forward to your questions.
Well, thank you. Mr. Adezada, you're now recognized for 5 minutes.
Mr. Chairman, members of the subcommittee, I want to thank you for inviting DAV to testify at this legislative hearing today. As you know, DAV is a nonprofit service organization. We provide a lifetime of support to all generation of veterans. And we've been helping more than 1 million veterans each and every year to better their lives and empower them. I'm pleased to offer DAV's views for your consideration on the bills for today's hearing. I'd like to start off with comments to H.R. 1506. DAV urges the subcommittee to pass this bill, the VA Healthcare Provider Education Debt Relief Act of 2017, which would improve VA's ability to compete with other entities in recruiting and retaining high-quality clinicians to take care of our nation's veterans and provide them comprehensive care. In our testimony, we make recommendations to improve this critical piece of legislation and make it stronger. One, we'd like to see the deadline for this program be extended beyond its current date. Two, we would like to make sure that there is increased funding for this program. And three, we'd like just the subcommittee to review the staffing for this program. According to VA, it requires 1 staff for any additional 1,000 participants in the program. And if we want to consider effective use of monies and keep VA accountable, I think that is something this committee should be looking at. As you're aware, the average debt that a medical student graduates in 2017 is about $190,000. And the student loan, this debt, weighs heavily on them when they consider their employment. And I think EDRP is one of the most successfully utilized programs that VA has. Combined with the caps that this committee had passed and agreed to in 2014, not only has the number of participants in this program increased, it has also increased the average amount of award, meaning for the same amount of money, we're having to provide more and more. Last year, GAO found that local facilities depleted their EDRP budgets early in the fiscal year. They were not able to commit to provide debt reduction payments to incoming students and clinicians because they simply ran out of money. This bill would also amend the condition on which VA could waive these statutory caps. We do ask the committee review that this does not, and we know this is not the intent, but we hope that it doesn't impinge on the ability for local facilities to use the current statutory authority in light of the ones that are being proposed now. DAV strongly supports H.R. 4334, the Improving Oversight of the Women Veterans Care Act of 2017. This bill would improve current efforts to ensure access to quality, gender-specific health services provided through community care contracts, as well as highlight VA facilities' performance in meeting standards that they have agreed to meet with regards to environment of care. As this committee knows, women veterans are about 10% of the veteran population in total, and it's growing. We've got 20% of new recruits are women veterans, 15% of active duty are women veterans, and 18% of Guard and Reserve are women veterans, female service members. The provisions in this bill, Mr. Chairman, are consistent with the recommendations of DAV's report. We issued a report in 2014. It's called Women Veterans, A Long Journey Home. This report spans the breadth and depth of all federal assistance that is available to women veterans. We make recommendations in every single one of those. We are in the process of updating this report, and we would be so happy to brief this subcommittee as well as the full committee on those findings. The AV also is pleased to offer its support for H.R. 4635, which would increase the number of peer-to-peer specialists to provide women veteran support and counseling tailored to them and their needs. We recommend the subcommittee consider adding funding for this program to ensure peer specialists are given priority among other critical clinical professional vacancies that VA has to fill. Mr. Chairman, VA's existing peer support program has been shown to be effective in assisting patients to not only become more active and more engaged in their treatment, but to be empowered, to be able to advocate for themselves, and it improves patient satisfaction as well as their quality of life. Facilities such as West Palm Beach, Chillicothe, Cincinnati, they've shown that this program is quite effective for their patient population. Women peer specialists are available to assist and guide other women veterans in accessing the services that they need, which is the bulk of this legislation for today's hearing. This concludes my statement, Mr. Chairman. I'd be happy to be pleased to answer any questions you or other members in the subcommittee may have.
Thank you very much. Ms. Dean, you're now recognized for 5 minutes.
Chairman Winstrup, Ranking Member Brownlee, and members of the subcommittee, Paralyzed Veterans of America thanks you for the opportunity to present our views on the legislation before you today. PVA supports H.R. 3832, the Veterans Opioid Abuse Prevention Act. Given the specialized needs of veterans, it is not uncommon for some to travel to different states to receive their care. And there is no assurance that the prescription data of a veteran who receives care at an SCI center in Minneapolis but lives in Wyoming can be shared. We urge the subcommittee to make sure these specialized patient populations are benefiting from the opioid safety measures in the same way as non-traveling veterans. H.R. 3832 is the means to do just that. PVA strongly supports H.R. 1506, the VA Healthcare Provider of Education Debt Reduction Act of 2017. We believe VA must be adequately resourced to attract the best and brightest medical professionals, and the Education Debt Reduction Program has been a markedly successful means to do just that. As there is a current and worsening provider shortage in the United States, VA must be able to insulate as best as possible veterans' care from this trend. That new residents are hesitant to take a post in an underserved community should come as no surprise. The cost burden of their education and training is an overwhelming prospect, and debt is all but guaranteed. No matter how eager to serve a new resident may be, a career at an understaffed VA may not be a tenable choice. And loan assistance can cultivate a culture of commitment from those unburdened by their debt and revive areas too long stressed by continuous shortages. PVA appreciates deeply the work of this committee this year on behalf of the caregiver program. Your staffs have maintained a thoughtful and open dialogue on the issues of the draft before us, and we thank them for that. The draft addresses, in part, the greatest malformation of the current program, the unequal treatment of veterans with the same service-connected needs. And for 8 years, VSOs have asked Congress to reckon with this injustice, and we appreciate the members' commitment to that goal. This draft does address it, but does so in a way that creates a different imbalance. It strikes the date of injury requirement, but raises the clinical eligibility from one or more activity of daily living to 3. And while this would make a still imperfect program, it is an imperfection that my members, veterans with spinal cord injuries, can endure a little easier, knowing that they and their caregivers are finally receiving the clinical supports and services their injuries require. Our support for this draft is not any statement on the work and sacrifices of those with 1 or 2 ADLs. Our position remains the full expansion of the current program. But my members can't unhear the ticking clock in their lives, not just the decades of work their caregivers have done, unsupported and unacknowledged, but the very real sensitivity of the time they have left to them and their wish to spend that time at home. We appreciate the cost and quality considerations of the draft, and while we support it, we do so as a first step. Because 2 activities of daily living due to injury or a disease are still activities of daily living that a veteran needs someone else to do because they were injured in their service. PVA's organizational mandate is to expand and improve the current program to all veterans with catastrophic service-connected injuries or illnesses. And in this moment in time, the means to most closely accomplish that mandate is the negotiated package that was to be included in the omnibus last month. That would see that the equal treatment of injured veterans is done by striking the 9/11 date. This issue is an urgent one, and aside from any consideration of cost savings of institutional care or the right way to do eligibility, the majority of veterans today are over 65, and those injured because they served are having conversations about what the rest of their lives will look like, and their caregivers are wondering if they can continue to do this alone. These families need the financial and clinical supports of this program right now. We ask the subcommittee to see that some relief in some form is finally provided to those who need it most as soon as possible. Mr. Chairman, PVA thanks the subcommittee, and I'm happy to answer any questions you may have.
Thank you very much. Ms. Kelleher, you're now recognized for 5 minutes.
Chairman Wenstrup, Ranking Member Brownlee, members of the subcommittee, it is my honor to represent the 1.7 million members of the Veterans of Foreign Wars of the United States and its auxiliary. The VFW is pleased to support bills H.R. 4334 and 4635. As you all know, women veterans are the fastest growing demographic within the veteran population, and the VFW has worked hard alongside Congress and VA to make sure they are able to access the best health care possible. While a lot of progress has been made, there is still room for improvement. H.R. 4635 would be an outstanding asset for VA to be able to increase the number of peer-to-peer counselors for women veterans who have survived sexual trauma, are diagnosed with post-traumatic stress disorder, struggle with other behavioral health conditions, or are deemed at risk for homelessness. With the hardships faced by these women, including increased rates of suicide and homelessness, this legislation would be an invaluable benefit. H.R. 4334 would be instrumental in providing oversight for Congress and VA. This bill would provide oversight for women who choose VA but must still receive care in the community for sex-specific appointments. By doing this, we would be assuring that patients still receive the highest quality of care possible. The VFW believes the expansion of VA's program for comprehensive assistance for family caregivers is long overdue and agrees with the intent of this draft legislation, but has very serious concerns with it as currently written. The VFW would oppose setting arbitrary eligibility requirements, such as increasing the criteria to 3 activities of daily living, in efforts to lower costs. The VFW also has concerns with other aspects of this draft legislation, such as the lack of provisions addressing caregivers and veterans graduating out of the program. Currently, when and if a veteran improves and is slated to be removed from the program, there's a lump sum totaling in 3 months of their stipend paid from VA. This abrupt ending has resulted in financial, emotional, and medical distress of the veteran and their caregiver. In addition to this, the VFW believes equity between DoD and CMS must be provided by including those who are made ill due to their service. Moving forward, the VFW looks forward to continuing to work with Congress in assuring the passage of the Community Care Package from S2193 that includes the expansion of caregivers, which the VFW supports. The VFW is happy to support H.R. 5520 for reiterating VA's current authority for research on medical cannabis. With over half of the country's states legalizing marijuana, along with the current opioid epidemic and ongoing forever war, the VFW believes it is medically irresponsible for VA providers to be left in the dark, not knowing about health outcomes and pharmaceutical interactions associated with medical marijuana. With veteran patients able to easily access medical marijuana legally, VA providers must understand the effects associated with patients' marijuana use. Many states and academic entities have already conducted research, and now is the time for the next episode of medical cannabis research at the federal level. Previous and current studies have found results showcasing how CBD helps patients with chronic pain and decreased opioid abuse relapses, an overrepresented health struggle for veterans. While other studies show THC helps with varying symptoms associated with PTSD and cancer recovery, also health concerns either overrepresented or of high prevalence within the veteran community. This is all in addition to high prescription rates from VA, though better than those in the private sector, for opioids, benzodiazepines, and SSRIs, with little to no data showing how marijuana interacts with these FDA-approved drugs. This is particularly troubling as the only 2 drugs FDA approved for PTSD are SSRIs, which studies published by AMA show SSRIs are no more effective than placebos for most adult patients. And other medical research shows that SSRIs are only effective on less than half the adult population with depressive symptoms. All while medical providers and researchers scramble with addressing the highly addictive negative outcomes that come with prescribing opioids, benzodiazepines, and other drugs. The VFW knows VA is a leader in medical research. VA researchers have even won Nobel Peace Prizes in the past. This is why we believe that VA should lead the way in allowing our country to better understand medical marijuana for the safety of our nation's veterans. Chairman Wenstrup, thank you again for the opportunity to present to you today, and I look forward to questions you or the subcommittee members may have.
Well, thank you all very much. I appreciate your testimony here today. True professionals, you all neatly stay right under 5 minutes. I appreciate that. But I'll yield myself 5 minutes for questions. I want to start with you, Mr. Celli, talking about the draft bill to allow VA research on cannabis. You said in October 2017 there was a nationwide survey conducted by the American Legion. Can you describe how the survey was conducted and what your findings were?
I can. Thank you, Chairman Wenstrup. We hired an independent research firm and gave them some really basic questions. Dear veteran, and they were responsible for going out and finding veteran households. They didn't use our members. Some of them may have been coincidentally our members, but it was completely independent. It was hands-off. We just waited for the results. And we asked them a series of different questions that gauged their interest in if cannabis should be legal medically, if the federal government should do research, if it should be rescheduled, and we have a complete printout of all of those results that we're happy to share with this committee.
What was the response on the research part?
The research was overwhelmingly positive in support of legislation that would allow for not only research, but also for medical use. Overwhelmingly, it was over 90%.
So from that, were you able to be guided in any way, shape, or form for what type of specific research that the American Legion may be interested in the VA doing?
So there's a host of different illnesses that the cannabis has been, that our veterans have told us that cannabis has been successful for. PTSD is certainly one of them, but so is inflammation, so is pain management, epilepsy. There's just a variety of different illnesses that this drug, which it is a drug, has been successful in patients with.
Well, thank you, and I appreciate if you would forward over the results.
Very much happy to do that.
That would be very helpful. Thank you for doing that. Mr. Adesato, you talked about the family caregivers and the stipend involved. What do you think is a more appropriate stipend schedule? What would that look like?
So, Mr. Chairman, before I answer that question, I just want to give a little bit of background about the discussion that took place that yielded what we have now. At the time that the stipend schedule was being discussed from statute to be made into regulation and implemented as a program, the idea was the population being served was undergoing tremendous stress and strain. And what the purpose of the goal of having what is currently the current schedule is to give them a sense of stability, that they can count on whatever modest stipend that they would be receiving would offer them some financial stability and not add to the stress. And so the idea that the idea that VA decided to use was specifically the BLS survey of homemaker health aid wages, which is referred to in the statute. Now, the statute and the law didn't specifically tell them to use that. That's just what the agency decided to use. And in its regulation, it had noted there was wide variation in the amount of homemaker health aid wages from any geographic region, from one to another. And that has led to these wild deviations from the norm or for the mean. And so we don't believe that the current issue with the stipend program being labor intensive as well as having such wide deviations in pay is necessarily based on statute. We think VA could regulate themselves out of this mess in using what this committee and holding its roundtable, there have been talk about maybe using a GS schedule, which is both geographically reflective, as well as meeting the intent of the law of being of not being any less than what a homemaker or malthate would receive pay for. So there are a number of schedules that VA can use that meets the intent of the law that doesn't incur this labor-intensive and this wild deviation of stipends.
Thank you. With that, I will now recognize Ms. Brownlee for 5 minutes.
Thank you, Mr. Chairman. My first question is really to all four of you, and thank you all for being here and your constant and steadfast counsel. Very, very helpful. So the question is, how would the lack of a grandfather clause, this has to do with the caregiver bill, the lack of a grandfather clause allowing currently enrolled veterans to continue to participate in the revised program impact the veteran caregiver community? In other words, we've got, two different sets of standards, and what do you think the impacts are going to be?
Yeah.
Thank you. The VFW, moving forward, we would not be in support of having two different standards between post-9/11 veterans and veterans who did serve beforehand. We do believe that including a grandfathering clause if eligibility requirements are to change is absolutely necessary. It would provide clarity to not just the veteran, but to VA as well, for what the standard for those currently on it are. If by any means that eligibility requirement did change, there needs to be something set in stone saying that individuals who are currently on the program, even if they are not at the same eligibility requirement or standard moving forward, saying that they're safe and they're going to remain on the program and continue getting the support and recognition from VA that they've been receiving.
Any other comments from
The American Legion could never support a bill that reduces benefits for veterans. Just as simple as that.
So PVA has recommended the use of multidisciplinary teams in caregiver eligibility assessments in the past, Ms. Dean. So what disciplines would you like to see represented on the teams?
So they already are being, that already is the way that the program is executed, is to use multidisciplinary teams as a way to sort of not allow for the whole decision to rest on one doctor at a facility, so that the pressure from the family or the veteran doesn't influence that one doctor's decision. So it's a team decision already, and I think that should continue.
So, Ms. Keller, on the medicinal cannabis issue, you stated, I think in your testimony, it would be medically unethical for Congress to allow VA providers to stay in the dark on medicinal cannabis. Could you expand somewhat on that statement?
Yes. As a non-doctor, doctors are required to provide ethical treatment. That's in the best interest of the patient. So particularly in the instance of VA, where it is a federal entity, and they are in states where it is medically legal, the VFW views it as being unethical for them not to understand the science and medical research behind the interactions, whether it be if CBD or THC is actually more valuable than a pharmaceutical drug, or whether it is that there is an interaction between one of the pharmaceuticals that they are taking with their recreational or medical use. So we view it as being unethical that, in a sense, VA, by not having this research or the lack thereof with federal research, that these providers just, they don't know, they're in the dark.
So, and to anyone who'd like to answer, this particular legislation allows the VA to do research, and I think that kind of codifies what the VA can already do, is my understanding. But don't you believe that we should have a bill that says, the VA should and must do the research in this area?
But, you know, I think that VA has really stepped up to the plate. Former Secretary David Shulkin had issued a memo stating that primary care physicians would have these conversations with their patients and in good faith, and would record that conversation in their medical records. Unfortunately, you know, to VFW's point, right now physicians don't have the clinical training because there is no research that the federal government supports that they can learn from. You know, it's a vicious cycle. We definitely think that the VA should do the research, but we also understand that VA's apprehension of wanting to be at cross purposes with federal law and their boss. So, you know, legislation is what they need. I think that's what we're here for today, and we support that.
Thank you very much. I have no more questions. I yield back.
Mr. Higgins, you're now recognized for 5 minutes.
Thank you, Mr. Chairman. Mr. Shelley, regarding your organization's position on medical marijuana, cannabis research, haven't there been thousands of studies around the world on this subject already?
There are, and you know, the nice thing about having those studies already at the federal government's disposal is that once they make a decision to study cannabis and take it off of Schedule I, put it down into, you know, a schedule that will allow medical institutions, allow colleges, allow the federal government to study it, they can then absorb those existing research studies, so they wouldn't have to start from ground zero. So it's very beneficial.
Isn't it, from specifically regarding the VA? Let's stay away from society in general for the moment. Mm-hmm. Much to the chagrin of my friend at the rear of the room. Let's focus on veterans. For a federal program, wouldn't there have to be a federally mandated standard of THC within the cannabis? And hasn't this always been the difficulty amongst the thousands of surveys and studies that have been done around the world? Is not the question of whether or not cannabis has medicinal value. That's certainly, I don't question it, and I support it, by the way. But our challenge, isn't it, to actually introduce cannabis medicinally into the federal system, the VHA system? Doesn't that challenge come down to the THC content and how to regulate that? You're talking about growing a plant. Or does the Legion support synthetic production of medicinal equivalent? And just share with us what your thoughts are on that, please.
Congressman Higgins, that's an excellent point. And what the Legion supports right now is research specifically to answer those very questions that you have. There is no standard dosage, there is no standard efficacy, there is no standard strength, and just like with an opiate, you wouldn't just randomly take a poppy plant, grind it up, and create your own opiates and decide that you're going to self-medicate. So the research absolutely needs to be done. It needs to be done professionally by scientists. It needs to be validated by the federal government. And then they can turn around and take this drug and they can distill it into whatever media or whatever delivery method that is appropriate for the patient based on the illness, and then they can deliver it that way.
Thank you for your clarification, and you have just very eloquently explained why I support this draft legislation. Mr. Addizado, I believe we should support veterans if they'd like to look outside the VA for their prosthetics. Reasonable accommodation should always be made to ensure that veterans receive the best care available according to that veteran's unique needs. Is it your understanding that the VA's policy pertaining to prosthetic and orthotic and other rehabilitative services have effectively changed, and are veterans now experiencing more difficulty or less getting the authorizations they need for the life-changing items when they use providers outside of the VA? Just share with this committee, please, your feelings on that.
Thank you for that question, Congressman Higgins. So a lot of our members use VA's prosthetics and sensory aid service by virtue of who our organization represents and are trying to serve. So over the years, the program, the service, has actually changed, And because fundamental aspects of the program has changed over years, it has impacted service delivery. But there is a catch. The change is supposed to have yielded some positive results, which we are still trying to engage VA to make sure that has happened, because there has been some problems getting the care and services and the items in a timely manner. We are very appreciative of VA actually creating, my understanding is a complaint line that patients can actually call and get their attention, get the leadership of the program's attention to address those situations in a more timely manner that has been occurring lately. And so, to your question, it has had some growing pains that it has adversely impacted patients who need this service. But we are working very closely with VA to improve them, because we hear from our members and other patients about these programs. And we can identify possibly policy issues or statutory limitations to just make it work better for veterans.
Thank you for your answer, sir. Very thorough. Mr. Chairman, I yield back. My time has expired.
Mr. Takano, you're now recognized for 5 minutes.
Thank you, Mr. Chairman. I want to just echo Ranking Member Brownlee's comments about the Family Caregivers Program, and I would like to back the sentiments of the American Legion that I would not support anything that would diminish the benefits for any veteran, and that I prefer what I see occurring with the Senate bill, which is to expand the current program to veterans to all eras as our best option. And so I just want to make sure we get that on the record now. But I want to move on to H.R. 1506, which has been the VA Care Provider Education Debt Relief Act of 2017, which has been offered by my colleague, Mr. O'Rourke. How can Congress ensure that the authority granted under this legislation to increase the caps for educational debt is properly implemented and utilized following enactment?
Thank you for that question, Mr. Kano. I would have to direct you to VA. Unfortunately, they're not here to answer this question, but the EDRP program is well tracked by VA. They can project with a good amount of certainty the number of new applicants that will be coming into the program, as well as how many are currently in and how long they will be in. And so I think if you work with the department, with that agency, in identifying what they believe will be the new demand because of these new caps, I think you'll get a very respectable answer as far as funding levels moving forward.
Well, Mr. Adesato, in your written testimony, you highlight the fact that the education debt reduction program is set to expire at the end of next year. What impact would that have on VA's ability to recruit and retain medical providers?
Well, so it would be quite devastating for these medical graduates, these clinicians. The awards under this program is usually a multi-year award. And so what you will get is a number of current participants who are probably are serving as clinicians in the VA healthcare system with an agreement that VA may not need. And so they will be saddled with these student debts that they thought would otherwise be taken care of, at least in part, or if not in whole, by the VA, suddenly find themselves having to repay those because of the extinguishment of this program. Not to mention the number of the thousands of vacancies that are out there that facilities won't be able to fill, simply because they don't have this as a tool at their disposal.
So you're saying it's a very important tool to be able to bring medical professionals into our healthcare system, that without it, these positions will continue to be vacant, or we could see more vacancies occur as people leave the VA through separations or retirements.
Well, yes, sir. So that's actually a very good point. If this were to expire and they have these loans that they need to pay, they're likely going to get released from the agreement and probably seek employment elsewhere where they can have those debts extinguished. But to the point, facilities use this program, the Education Debt Reduction Program, as well as another program called the Relocation, Recruitment, and Retention Program, the 3R program. That program actually suffers from a cap as well, much like this. And so those two are actually very important tools that local facilities use to recruit new medical graduates as well as retain high-quality health professionals within the healthcare system. And because those two are under stress now, to us, we understand why VA's vacancies remain as high as they are.
Wow. I hadn't heard about the caps on this other program. What is the program called again? The 3R, you said?
So it stands for Recruitment, Relocation, and Retention. It got swept into the VA Choice Bill that was enacted back in 2014, and it was swept into the cap for bonuses being paid. So we actually supported the idea of limiting bonuses being paid to clinicians because of poor performance, right? But the 3Rs is not a performance-based, it's actually a recruitment and retention instrument, but it somehow got pulled into those caps, and so we've been working very closely with not only the full committee, but the Senate VA committee to address that issue as well.
All right. Well, thank you very much. My time is up. Sorry I went over, Mr. Chairman. I yield back.
Mr. Rutherford, you're now recognized for 5 minutes.
Thank you, Mr. Chairman. First, I'd like to say that I'm a strong supporter of improving and expanding the loan repayment program at VHA. And that's why I offered my VA Physician Recruitment Act, which includes that loan repayment, as an amendment to the choice legislation that the committee agreed to and moved earlier last year. Everything Mr. O'Rourke said highlights the fact that we've got to get this right, and we've got to get it right soon, because half of all providers in VA will retire, are eligible for retirement within the next 10 years. That's a scary thought. And what's even scarier is the Senate Choice Act. Their proposal still extends the graduate medical education program as a way to bring more doctors into the system. However, in hearings that we've had with the previous secretary and Dr. Clancy, we've learned that number one, this is more expensive, less effective, and potentially brings in less qualified physicians to care for our veterans, where loan repayment provides VA with more flexibility to recruit the most qualified candidates. And so, Mr. Adezato, can you give me your perspective on the GME versus the loan repayment? The GME as it still remains in the Senate Choice Act.
So, Congressman Rutherford, I first have to let you know that I think we do support the GME proposal. We think VA needs, frankly, needs every tool in the bucket that they can have in there. Certainly GMEs have its own purpose, and it's successful in its own way, but I don't believe the two should be seen as a competition. I think they both work in different ways to enhance the local facility, fill a critical need. I think GME works in areas such where there are facilities who have very strong affiliate relationships, where they have that pool of talent that comes in to help care for veterans, both in the academic institution as well as in the VA facilities. And I think that program works very well, but not all facilities have that kind of a relationship with an affiliate. And so these other tools, these financial incentive tools, become more important for those other facilities. So I think those two are good programs.
Complementary?
Yeah, I believe so, yes, sir, for the whole system as a whole to address its workforce shortage issues.
Okay. Anybody else want to comment on that? GMEs versus loan repayment? Okay. Let me share this experience too. Mr. Chairman, when I was sheriff in Florida, I had an opportunity. I was a legislative chairman for the Florida Sheriff's Association when we actually, as an association of 67 sheriffs, advocated for Charlotte's Web, which is an extract of cannabis, very high in CBDs but low in THC. And I have seen, I can tell you firsthand, the results of Charlotte's Web on a little girl who was around 8 or 9 years old, suffering tremendous number of seizures every day. Her legs, she couldn't get out of bed, her legs had atrophied. With Charlotte's Web, a year later, that girl was up walking around. That's why I support this idea that we have to look at this drug, see what we can do to help individuals with a drug that I think for too long we've just mischaracterized. Well, I don't want to. I'm not defending marijuana, but I am saying there is a medicinal purpose and efficacy there that I would like to see studied. And so, with that, Mr. Chairman, I'll yield back.
Mr. O'Rourke, you're now recognized for 5 minutes.
Thank you, Mr. Chairman. Mr. Chairman, I got to say I really appreciate the conversation today and the fact that on almost every one of these bills there seems to be bipartisan agreement on what it is we're trying to do here. Very helpful feedback from the panel, some constructive criticism that on at least the bill that we've authored, H.R. 1506 will incorporate into the changes that we will propose. And I agree with some of the panelists that perhaps the only complaint I have is that some of these bills do not go far enough. And love what the chairman's doing on the family caregiver program, but want to make sure, as one of the panelists said, that this is just a first step. It doesn't get us to where we are. And I think implied in some of the questions about medical cannabis is how much more study do we need to do for something that's legal in 29 states, that doctors are already prescribing, that veterans in Texas at least come up to me at town hall meetings and say, this is the only thing that I can take that makes life livable for me, but I'm treated as a criminal under the law in this state. How screwed up is that? And if we're going to wait for study upon study upon study for veterans to get the care they need, especially if it is an alternative to opioids, from which veterans are dying of today. I had a town hall meeting in El Paso. A veteran came forward and he said, listen, the VA cut off my opioid prescription. And I understand why the VA is doing this, but they didn't provide an alternative in its place. And he said this in front of 200 people at the town hall. I'm buying heroin on the street right now because this is how I can take care of this issue. I think we've got to go, within the bounds of reason and medicine and science as quickly as we can to making sure that doctors can prescribe what they think is in the best interests of their patients, including cannabis or marijuana. I think we're there. Just given the number of states who are there, the number of countries who are there, the number of veterans who need it, I mean, let's get there. On the debt repayment issue, again, and we authored it, I don't think it goes far enough. I mean, that's my complaint. We should be much more aggressive in raising the caps. And if we've got between 30 and 40,000 vacancies, let's be aggressive on that. I mean, there are people literally dying right now because they cannot get in to see an appointment. We still have a crisis in veteran suicide, though the last secretary made it his #1 clinical priority. And so I think, especially in those underserved, in-demand professions, I think of psychiatry and the need for those who treat traumatic brain injury and post-traumatic stress disorder. Let's make it as easy as possible to make the choice to practice medicine in the Veterans Health Administration or to stay there if you're already there. And I think everyone's on the same page. It's just I want us to be as aggressive as possible. And so your comments about making sure that this is funded, that we get past the sunset, and that we do everything within our power to make this attractive hit home. And I'll do everything that I can. And I think within the context of $1.4 trillion in outstanding student loan debt, why do we make it so hard for people to better themselves so that they can do better for their fellow Americans, especially in the VA? This is an investment this country absolutely should make. And so I hope there's bipartisan commitment to actually fund what we're proposing to authorize. So I don't really have a question. I think you all did such a great job in providing your feedback, and we're taking notes on all this, and just want to tell you that we're grateful for that. And I'll yield back to the chair.
Thank you, Dr. Dunn. You're now recognized for 5 minutes.
Thank you, Chairman Wenstrup. My principal interest today has been the Veterans Opioid Abuse Prevention Act, one of the bills we're considering here. I don't have the sense, as Mr. O'Rourke said, I don't have the sense of any pushback from anybody, but I want to poll you, explicitly. Is there? Do you have the sense of, in any of the VSOs, that there's opposition to this prescription database sharing plan? Any of you, or all of you?
So, based on the feedback from our veterans, it's not that there would be opposition to it, it's that there has been such a pendulum swing of, the opioid crisis with veterans who are in chronic pain and on systemic lifelong opioid prescriptions. They're very concerned that their prescriptions will be reduced and that they will not be able to perform the daily functions that they are currently able to enjoy now. So anytime there's, there's legislative efforts or efforts by our federal government to try to curtail the abuse, the patients who are taking this as prescribed get very nervous. So that would be the only thing. And the only other thing that I would add to that is, if we had the lifetime electronic medical record, we wouldn't need additional legislation specifically to track prescriptions. So I think that we have work to do in both of those areas.
So I appreciate that comment as a surgeon myself, and I don't look forward to having my hands tied on how long I can prescribe a medicine for. I don't know that I can say that won't happen, honestly, because as you've hinted at, the government tends to overreact when they react. So buckle up. It could be a bumpy ride, but I do agree with that. I do also want to make one more comment about the cannabis research. We have a form of legal cannabis now that really has almost no abuse history at all. Very effective. It is actually tetrahydrocannabinol, the stuff that makes you high in cannabis. And I just looked it up because I wanted to be sure I was right. It's a Schedule III drug, so it should be very easy to research on at least that form of that cannabinoid, which is just one of dozens to hundreds of cannabinoids in a marijuana plant, and it's different than the cannabinoid that Congressman Sheriff Rutherford mentioned, which I'm familiar with and is effective against seizure disorders in some children, and certainly we want to make that available. It is available in Florida to children. I don't see a lot of veterans with that particular affliction because it affects infant children. But I think we could study the THC in the Marinol. It's the generic name is dronabinol, and it's just tetrahydrocannabinol. So I don't know if you have any comment on that, but it's available, and it's actually be pretty easy to do research on a Schedule III drug, I think. Any thoughts?
Well. The only thing that I would add to that, and I'm not a scientist, but I do know that there are components within that tetracannabinol that are in the Schedule 4, or in Schedule 1 rather, that prohibits the federal government from authorizing.
But so that's on marijuana plants. But I'm just saying, if you want to do research on THC, tetrahydrocannabinol, you can go at it all day long. And it's not even a particularly controlled drug. I've prescribed it, and it's only used currently for anorexia and for pain potentiation in typically terminal patients. But it's a very available drug, and I've never seen it abused. I've never seen it stolen. Never heard of it, walking out of a pharmacy. I wish Buddy Carter were here, but I think it's a pretty, available drug for study right now. I have no other questions, Mr. Chairman. I'm happy to yield back.
Ms. Custer, you're now recognized for 5 minutes.
Thank you very much, Mr. Chairman, and thank you to all of you for being with us. I just want to join my colleagues that these are predominantly bipartisan bills, and it's great to make progress here in the Veterans Affairs Committee. And I have joined as a co-sponsor on most of the bills. I want to direct some of my concerns. I appreciate the efforts that Dr. Rowe has made to come up with a bipartisan compromise on the benefits for family caregivers, but I still am concerned about the policy proposed and the fact that it doesn't really resolve the fundamental lack of fairness between our post 9/11 and pre 9/11 veterans. This is just directed at any of the VSO witnesses. Besides increased cost to the VA, is there any other reason not to expand the program to include all veterans of all eras that require home caregivers?
We believe it's only a cost issue.
Yes. The VFW doesn't see any reason to not expand to everybody as is. We do understand there's constant concern and some criticisms on VA for the way the current program has been implemented and road bumps that they have undoubtedly had along the way. But again, VFW doesn't look at that as a reason to not expand for all eras of veterans.
I mean, sometimes, this is just my impression, I think we spend a whole lot of money trying to limit care and determine who's eligible for what, and I really like the way you said it, that, you know, being unable to do 2 activities of daily living is a major constraint on someone's life that you need help with. So could the VSOs explain some of the potential unintended consequences of expanding benefits to only those with 3 or more activities of daily living? So just briefly, examples of how that would be a problem.
I think we've seen it the last 8 years of the program as is, right? That this inherent unfairness about people who need these services but are just not allowed because of an arbitrary date. We're picking a new lucky cohort, essentially.
Well, now we're not only having an arbitrary date, but now we're having an arbitrary number of issues that you might have, which is, I can't imagine medically that has any basis in reality. And then could you give us some examples of veterans that would not qualify for expanded benefits but reasonably might need additional help? Anybody have an example of what this might look like?
So in the current program now, you have a significant majority who would fall under the 1 and 2 ADL who would have to be transitioned out. And I can't even imagine the impact on their lives, not only the veterans, but the caregivers and their families as well, if that were to happen. I do want to make sure we understand, though, you know, the intent of the legislation is to expand the program within certain constraints, and so we appreciate that work. We very much appreciate the work that Congressman Rowe has done, and staff has done to talk to us about how to do this within these constraints, and we appreciate that. But to echo my colleagues' comments, we have an opportunity, we have a historic opportunity before us, before this committee and the Senate and Congress, to actually not even have to talk about the proposed draft bill, because we are talking about actually expanding the current program to all eras. And I really have been thankful of my colleagues' support and all the members' support to try and make that a reality this year. And so I'd prefer we actually focus on making that a reality and then pick up, if that in case doesn't happen, then perhaps take up this conversation after.
Well, I'd love to work with you on that. And I certainly think that's the direction we want to go. Otherwise, I just want to join my colleagues. Anything that we can do to improve access to care for women veterans and also the veteran opioid abuse prevention. This is something that I've dedicated the past 5 years of my life. We have a bipartisan task force with 105 members, Republicans and Democrats trying to tackle the opioid epidemic all across our country. And I think the VA is where a lot of the innovative solutions will come from, both to lower the rate of opioid prescriptions by using alternative pain management, and also to help with this prescription monitoring program and help with more efficient and effective methods for, for treatment and long-term recovery, and I yield back.
I want to thank everyone once again. Thank you all for being here. Appreciate all the input you provided with us today. And the second panel is now excused. I ask unanimous consent that all members have 5 legislative days to revise and extend the remarks and include extraneous material. Without objection, so ordered. I'd like to once again thank all of you, our witnesses and audience members, for joining us this afternoon. The hearing is now adjourned.